a community of about 30 to 70,000 people. And the health system has to consist of components. One is it can't be thought of in a vacuum. The health system is very dependent on these other sectors, such as education, infrastructure, and agriculture. You cannot have a successful health system if at the same time the community is not food secure, if at the same time the community has no roads, ambulance, or telephony to transport emergency cases to where they can get care. There is no health system if children are not at school learning how to better take care of themselves, keeping girls from early marriages and early pregnancies. And so the cross-sectoral component of the health system is very important. The second component is the continuum of care. The focus is making sure that there is one clinic for every 5,000 people, and that the clinic, sort of the gold standard is that it has to be able to do basic emergency obstetric care, which means that there has to be a skilled birth attendant. But in spite of this much improved ratio of 1 to 5,000, meaning that there has to be a clinic within walking distance to every household, within a short walking distance, maximum of 2 hours, it turns out, it's been shown by many projects and many studies, that in spite of that, even if you have a clinic that's within a proximity, and even if it's free of charge, which is a sine qua non for our recommendations, that there has to be absolutely no point of service fees, even then, there are households who do not access health care. And that's why, of course, many groups, including ours, is working very hard on deploying a professional cadre of community health workers. By professionalized cadre, I mean that they are actually they're formal members of the Ministry of Health, that they're paid, that they are managed, supervised, well-trained, and supported. And then for it to be a real continuum of care and a really self-respecting health system, you of course need a functioning link, both physically and by telephony and by communications between the clinicians to a referral hospital. So in our cluster, there is a rural hospital within a short distance from the primary health clinic. And again, sort of a shorthand way of saying what the referral hospital should have, I'd say that the gold standard is that it has to be able to do comprehensive emergency obstetric care, i.e. be able to deal with obstructed labor and be able to do a cesarean section. So the main construct, I would say, is that free point of service care, professionalized outreach, and then the continuum of care so that every household is connected to a community health worker who can do preventive, promotive, but also treatment of diarrhea, malaria. Now with the RDTs, the rapid diagnostic test, the community health workers can actually do malaria, diarrhea treatment. They can do screening for malnutrition. And the point is to make sure that every household is connected through the community health worker to the clinic, to the referral hospital. And one more thing that we found is absolutely critical, and is why we went from the project adding $50 per capita to making it $60, because we found that it's very critical. What we thought was just going to be project related, but it actually is a critical component of any health system of a cluster of 30 to 70,000 people, is a management team. A public health manager has to be present and oversee this whole ecology of activities. So what are the results? Some of these results, I've had partial results last time I was here, but now we have the year 3 results from the surveys, year 3 from all of the sites in the project. And so I'd like to quickly just scan through those. So this, always on the left, is the pre-intervention, and the bar on the right is post-intervention. And so from Kenya, Ghana, Malawi, Nigeria, I can't see, Tanzania, Mali, I can't see what that says. The harvest with the improved seeds and the fertilizer, which has not been used at all by these communities, they could not afford it. Within one growing season, they improved their yield. Amazingly so with people who live on grain, on corn, I'm sorry, and also increase with some of the other crops. What this allowed the communities to do, given that within the first growing season, i.e. almost 4 years ago now, the fact that the communities became food secure changed everything. It made it so that the families were for the first time able to actually have enough to eat between harvests. They had enough to donate to the school for school meals. It meant that they could for the first time actually go to the market with some surplus. It was the first time that they were able to earn cash, and it was therefore the first time that they could actually save and invest into different forms of livelihood, and it's been transformative. No, that's not what I want. Where is it? This just sort of shows that the opportunity, since we're working in all the different sectors, not just health, how you can really follow the impact pathway. So here it's one of the clusters where you can see that they were only basically subsisting on a couple of items, and then once the intervention started and the yield of the harvest yield increased, then and only then were the families, the villagers, able to start using less of their land for the crops, since the yield was more fertile, and they were able to use the rest of the land for other diversified crops and get into other forms of livestock. And so you can just see how the diversification of their agriculture and livestock has improved tremendously from the beginning of the project. That, of course, translates into, since we do food frequency questionnaires, this graph basically shows you glasses. Again, the blue bar is, these are all the different food groups. The blue bar is pre-intervention, red bar is post-intervention, and you see that there is increasingly more red bars, which means that the families told us that they were starting to eat more and more vegetables, legumes, different fruits, also sweets, unfortunately. But meats, eggs, etc. So their diet became more diverse, and we, because we collect blood samples, also saw this translated in that the vitamin A deficiency in the children's serum was proven to be decreased by almost half. Sorry. And so this increased yield in the harvest, increased diversification of agricultural and livestock, increased diversification of the diet has led to the following results, which I actually have to tell you I found remarkable when we saw this. So this is 3 years post-interventions in all of the clusters, 14 clusters. We looked at the indicators for malnutrition in children under 2. Within 3 years, again, on the left side is pre, and on the right side, the darker, is post. Underweight and wasting decreased. This wasting was not significant, so acute malnutrition, although relatively low to begin with, did not decrease that much. Underweight did. And the part that was literally stunning to me was the stunting, which, by the way, just to show you, all of the Millennium villages were really the hunger hotspots in each of the countries that we worked in. They were chosen to be the most remote, the most difficult, with the worst indicators. As you can see, they had 46% of their children were stunted, which is just tragic. After 3 years of the interventions I described, the stunting decreased remarkably, and this actually is so remarkable. So it went from 45% to about 32%, and this is so large that, of course, we didn't believe it, and neither does anybody who looks at the data with us, but we've checked it over and over again, and it's actually true, correct finding. And the reasons, in retrospect, are actually not so surprising, that the stunting could be impacted on so dramatically in 3 years. And it's because we're, in fact, trying to help the communities impact on all the different pathways in the impact pathway that leads to malnutrition. Whoa, this didn't show right. Oh, I don't know what to do about that. I'm sorry. This is a much busier slide. I'll just tell you about it. I'm sorry, there's this whole thing missing here. But basically, the reason that I think we're finding this serious reduction in stunting is that with this kind of a holistic project, you really are impacting on what nutritionists call nutrition-sensitive inputs. Nutrition-specific, nutrition-sensitive, which are these two. And so since we're impacting on all the different things in the impact pathway, it really does give you this result. So the nutrition-specific immediate causes that the community is working on is all of the things that to do with health. At the household level, it's breastfeeding, hand washing, feeding. The CHWs are measuring with the mid-upper arm circumference. They're screening for malnutrition, thereby early detection leading to earlier treatment. At the clinic, of course, growth monitoring, etc. So there's a lot going on in the food, in the nutrition-specific area. And then, of course, in the nutrition-sensitive is just the fact that the project, of course, helps improve food security, and that there's all the ancillary services that also are underlying the nutrition component. And then, in addition to that, it also addresses all of the other underlying causes of malnutrition. So, in fact, although we were first surprised, I think in retrospect, it would be really surprising and hard to explain if given the fact that I have a list of 80 things here that are not showing up, given that that all of these things were impacted on, if it didn't lead to the decrease in stunting. Oh, I see. That's fancy. I didn't do that. So these are the learning. You should have seen me in Harvard School of Public Health, where I was at the age of 10 years ago, at the age of 47, the oldest thing that Harvard ever had in the School of Public Health. And all my classmates, of course, were completely facile with PowerPoint presentation, and all I knew is how to stand at the blackboard with my chalk, looking very anachronistic. And I wanted to show you how completely fluid I am with it, but I guess I show my age. So these are the communities, the Millennium Village concept is that you're really impacting on all the different inputs. So these are the health, these are the nutrition-specific interventions. These are the what the nutritionists call the nutrition-sensitive interventions, of course, improvements in agriculture, and then all the elements of health that would predispose to malnutrition, and then the societal nutrition-specific interventions. And so this is the impact pathway leading up to the nutrition indicators. In child health, what we found is that all of the sites together, this is all averages of all of the sites,